All right. Hey there, all. So it looks like at the moment it is just me. I always just like to mention that just because those of you watching the recording, it might seem strange that I'm just in here going and nothing else, like I'm ignoring everybody. It's just me in the room right now. So anyway, I will just continue and record. And hold on one second. I'm just adjusting something in my settings real quick. That's blocking my view here. So just give me a second. Okay, there we go. There we go. So yeah, I'll just go and continue to review this stuff. We'll see. Maybe some people will join. And of course, like I always said, if anybody has any questions when they're sitting here watching this recording, you're welcome to email me if you have any questions. I think for the most part, everything in here, trust what we're covering, trust what's in the notes. Like everything in here is self-contained. But if there's something that's unclear to you that you don't understand, I'm always happy to go over it however you need. All right. So just to remind people where we left off last time, we would have gotten through the cranial nerves, and that overlapped with anatomy physiology too, like just the basic, like, hey, here are the cranial nerves, the names, the numbers, what they do. And then it also included some of the O&E1 material, which is like, how do you test those cranial nerves? And like we were saying before, like a lot of the cranial nerve testing should be relatively intuitive if you know what the nerve does. So, for example, if you know the cranial nerve 7, the facial nerve, if you know that moves the muscles of the face, then if you want to test if the nerve is working, you ask the person to move the muscles of their face, like, smile, wrinkle their forehead, that kind of thing. And if everything moves, it must be working. If one side maybe doesn't move, then possibly there's something wrong with that nerve. So, anyway, that is where we left off. Now, there is a little bit more. So, that stuff came up a lot in O&E1 as part of the 5 minute neuro. The other part of the 5 minute neuro that does come up on the comp exam is this other handout that I'm going to pull up here, a little bit of a separate handout, the myotomes, the dermatomes, and the DTRs. So let's go through with what you need to know here. So remember the concept here that you learned how to test in O&E1. The concept is that if one of the nerves that's exiting the spinal column, one of the spinal nerves that ultimately feeds into various peripheral nerves, if one of those spinal nerve roots is being pinched, then that could disrupt the neural signal, either going out to the muscles or the ones coming in, the sensory signals that are coming in and then go up to the brain. There might be some kind of disruption, some kind of altered signal. And there's certain things that indicate that it's more likely a particular nerve root that's the problem. So let's kind of go through these things here. So we have the myotomes. The myotomes refer to a muscle action that is primarily linked to a particular nerve root. We'll say spinal nerve. Now, it doesn't mean that there's not some other spinal nerves that maybe contribute some axons to the peripheral nerves that control that muscle action. But primarily, there's one nerve root that tends to make up most of the axons that are going to contribute to stimulating that muscle and creating that muscle action. So if somebody has weakness doing that particular muscle action, it kind of gives you a hint that it's most likely this particular nerve root that's being pinched or compressed or is defective in some way. That's basically the concept of the myotome. And these are graded on a 0 through 5 scale, 5 being perfect. I mean, don't be literal about that, right? Nothing's perfect, but 5 is what you want. Now, on the comps, I've never seen anything come up that delineates between like the difference between a 3 and a 4 or something like that. You just want to know that when it comes to the myotome scale, 5 is what you want. Anything less than that means some degree of weakness, and therefore it implies some type of problem with the spinal nerve that ultimately influences that muscle action. So I've not seen any questions where you're going to have to delineate whether somebody should get a 3 or a 4, but you should know if they tell you that a particular myotome was assessed as being a 3, for example, you should know that that means something's wrong, that's a bad thing. Whereas if it's assessed at being a 5, you should know, okay, that means that's good. That's what we want. All right. So make sure you know the general concept of a myotome, and then you need to know what muscle actions go with which nerve root. So, for example, if somebody has some degree of weakness when doing shoulder abduction, that implies something's wrong with C5 potentially. The C5 nerve root is being pressed. There's maybe a bone spur pressing on it. Maybe the opening of the vertebral column is too small and it's pinching it, some degree of stenosis. Maybe there's a disc herniation pressing on it, even though that's more common in the lumbar spine, but that kind of thing. C6, wrist extension. So if they had some kind of weakness with extending their wrist, like if their wrist like kind of droops like this and they have difficulty extending it, that would indicate that it's a C6 problem. And then you can kind of go through the rest. Wrist flexion, so doing this kind of action against some degree of resistance, that indicates C7. Finger flexion, making a fist, gripping something, C8. Finger ABA deduction, this kind of thing. So remember, usually would have the patient, hold their fingers out and you do this, or you'd put your fingers or something in between and say, okay, grab my fingers, don't let me pull out. So they have weakness in any of these actions. It indicates the corresponding nerve root might be the problem. Then hip flexion, you have them flex their hip up into you press down, have them flex their hip against your resistance. That can indicate L1 or L2 problem. Knee extension. So like kick into, you press up against their tibia and be like, kick into my hand. Weakness there. L3 problem. You have them dorsiflex their ankle against resistance. A lot of times what you do is you put their ankle into dorsiflexion and tell them to hold that against your attempt to put them into plantar flexion. If they have weakness, L4 problem. Big toe, like, okay, press your big toe up into my finger. Weakness, L5 problem. Plantar flexion would be like, do they have weakness like standing on their toes or something? This kind of thing. So the questions on the comps don't really get too complicated with this. It's more like they tell you a particular action was weak. Which nerve root do you think is the problem? So they'll tell you like wrist flexion was weak, shoulder abduction was weak. Which nerve root do you think was the problem? Or they'll use the grading scale. They'll tell you that like shoulder abduction was graded at a 3. What does that indicate? And then you would have to say, oh, that's a C5 nerve root injury, something like that. And of course, it can go in the other direction. They can tell you that somebody has a C5 nerve root injury. Which of the following do you think they would show weakness with, that they would have difficulty with? And you'd have to know, oh, that's shoulder abduction. Or if there was an S1 injury, they would have difficulty plantar flexing, difficulty standing on their toes, that type of thing. So that's the way those kinds of questions tend to come up when it comes to this topic. All right. So again, make sure you know the general rule of what a myotome is, the grading scale, and most importantly, which muscle actions correspond to which nerve roots, because most of the questions are just going to be that. Wrist flexion, C7, finger flexion, C8, finger abduction, adduction, T1. That's most of this. Remember, you don't have to perform this. You're not doing the 5-minute neuro. You just have to be able to answer questions about it on a written exam. All right. Then the DTRs, the deep tendon reflexes. So DTR stands for deep tendon reflex. DTR for short. This is A reflex, I mean, it's the same kind of concept, a reflex that primarily corresponds to a particular spinal nerve. This is also a 0 through 5 grading scale. But remember, in this case, 2 plus. They don't always say the plus sign, but you may remember from class 2 plus being perfect, but they could just say 2. So that bottom line is 2 or 2 plus is what you want. And that's because remember, with reflexes, you could have reflexes that are too aggressive and also reflexes that are too weak. So, in other words, kind of in the middle is what you're aiming for. And then it could be an excessive reflex or it can be a deficient reflex. And that would lead to lower scores or higher scores. Where muscle strength, like there's no such thing as too strong, right? 5 represents full strength, and everything less than 5 is varying degrees of inferior strength. Now, again, just like we were saying about myotomes, I've never seen any questions that delineate between like what's the difference between a 3 and a 4, or what's the difference between a 1 and a 0. Just make sure that you know 2 is considered good and anything other than 2 indicates a problem. And then, of course, just like we were saying for the myotomes, you want to make sure you know which reflex goes with which nerve root. So C5 is the bicep reflex where you hit the bicep tendon with the hammer and you get a little boop. C6 is the brachioradialis one. So that's the one where you kind of hit up here and the wrist kind of go boop. C7 is the tricep one. So that's the one where you kind of hold like this, hit the tricep, and you get a little boop again. Then not everyone has a reflex. Not every nerve root has a reflex associated with it. Cremasteric reflex, don't really worry about that one. It's on this particular handout, but it's not something that you'll be tested on. I'll just tell you though, I mean, basically the cremaster reflex is if you stroke the inner thigh, the cremaster muscle contracts and the testi will get pulled in an upward direction. So obviously that's not one that you practiced in class. But then L4 is the patellar reflex. So that's the one where you hit the patellar tendon with the reflex hammer and the tibia kind of kicks out. And then S1 is the Achilles reflex. So you hit the Achilles tendon with the reflex hammer and the ankle joint kind of does a little dorsiflexion. Or I'm sorry, plantar flexion. Plantar flexion. So if one of those reflexes is either not happening at all or is weak relative to the other side, most of the time it's like you're comparing to the other side. So if it's weak relative to the other side or it's aggressive compared to the other side, then it's going to get a score other than 2. If it's weak, it's going to get somewhere in the 1 or 0 range. If it's too aggressive or leads to clonus, then they'll get varying numbers of 3, 4, or 5. All right. And again, if the person said to have a 2, that means that's what you want. That's good. So again, questions are pretty straightforward. They might just tell you something like the patellar reflex was absent. Which nerve root do you think is the problem? Something like that. Or if somebody has an injury that's affecting their L4 nerve root, which of the following reflexes do you think might be absent? Something along those lines. And then lastly, dermatomes. This is an area of sensation that corresponds to a particular nerve root. Or you could say spinal nerve because the nerve roots feed into the spinal nerve. So same kind of thing. And here, like there are various different scales when it comes to dermatomes. There's all types of pain scales and things like that. But as far as, comps go and just sort of the general rules, essentially you just have normal versus abnormal sensation. There's not like a 0 to 5 or anything like that for the general concept of a dermatome, but there are like various pain scales that have been developed. Here, they'll basically tell you that somebody has some kind of abnormal sensation in a certain area, and then you're supposed to know like what nerve root that area corresponds to. So abnormal sensation is anything other than that sort of just like regular sensation of like, how your body feels. So if there's like pain, that would be an abnormal sensation. Tingling would be an abnormal sensation. Numbness, any of that kind of stuff. So they'll essentially tell you that somebody has pain or tingling or numbness in a certain area, and then they'll ask you what nerve root that corresponds to. Or again, vice versa. They'll tell you the nerve root has some kind of injury, and they'll say, where might you expect they would feel pain or feel some kind of abnormal sensation? So you want to know what areas correspond to the nerve roots. And this is the whole thing where C5 is kind of essentially the lateral aspect of the upper extremity here. Then C6 is more in the lateral aspect of the forearm into the thumb and the index finger. C7 remembers the middle finger and like kind of a little strip there. C8 is the ring finger and the pinky finger. And then this medial aspect of the forearm. And then T1 kind of up in here. And then you have the same sort of thing on the lower extremity. And again, it's all listed here. So just make sure you know that if they tell you there's numbness or pain in a certain area, what nerve root does that correspond to? All right. And just keep in mind that somebody that has an injury to a particular nerve root, it may just affect the motor fibers, it may just affect the sensory fibers, or it may affect everything, right? So if somebody had a C5 injury, for example, they might have weakness with shoulder abduction. They might have an absent or deficient bicep reflex on that side. And they might also have pain or numbness that radiates down, into this general area. But not always. Sometimes it depends on the specifics. It might just be the sensory fibers that are affected, in which case the dermatome might be affected, but everything else might be okay. It might just be the motor fibers that are affected, in which case the myotome might be defective in some way, but maybe the sensation is normal. Reflex is kind of in the middle because reflex involves sensory input and motor output. So, depending on all the particulars, a reflex may or may not be affected. All right. So, this handout should be pretty straightforward as far as what you need to know. And that's O&E1. Between this and the cranial nerves that we mentioned last time, I mean, that's really the most of the new information that you learn in O&E1. So much of O&E1 is practicing for doing the 5-minute neuro, but as far as written information based on that, yeah, it's just kind of all this. So if you know the cranial nerves, these, you've basically got O&E1 for comp purposes. You're good with that. All right. Okay, so let's go back now then to this handout and wrap it up. So on this handout, if we scroll down, we have a few things under general pharmacology. Now, remember that most of the pharmacology we've really already discussed because it's bound up within other topics. So, like as we were going over the cardiovascular handout, we mentioned things like cholesterol lowering medications. We mentioned things like blood thinners, anticoagulants. We mentioned blood pressure medications and the various side effects and all the different types. So, a lot of the pharmacology that can come up on comps we really already mentioned. The stuff here, this is just the kind of the broad brushstroke stuff that doesn't really fit neatly into any other topic. So that's what we mean we say general pharmacology. So for example, you may get some questions on the concept of the therapeutic index. Remember that the therapeutic index, now if you think to your pharmacology class, this may be more complicated in class because I think if I remember class, they show you a graph and there's the whole thing with like under the curve and over the curve. The comps isn't get into that. You just have to know the broad concept. So the therapeutic index is basically the safety window. It's the ratio between the toxic dose of the medication and the therapeutic dose. In other words, in order to get a therapeutic effect, you need to give at least this amount. Otherwise, there's no point in giving it, right? You need to give a certain dose in order to get a therapeutic effect. Otherwise, there's no point. However, if you give beyond this dose, it might lead to some toxic effects. In other words, there's a window between that therapeutic dose that you have to give, that sort of minimal dose, and that maximum dose, where if you go beyond that, there could be some kind of toxic side effects. It doesn't necessarily mean that it causes death, but it may cause various dysfunction in the body and harm. So the therapeutic index is that ratio, that difference, that window of use. And basically, you want to know the general definition of it, and you want to know the idea that we would prefer drugs have a big therapeutic index. You want a big window. Then you don't have to be as worried. You don't have to be as careful. The more narrow the therapeutic index, the much more cautious you have to be. You know, if it's one of those things where, like, here's the minimum dose and here's the toxic dose, and they're really close, you only have a very small window of safety. You've got to be very careful with dosing this patient, instructions. You have to be really careful about what medications you combine it with, because anything that might affect metabolism or affect elimination or affect protein binding could influence how much of this drug builds up in the body. And if something has a narrow therapeutic index, you got to be really careful about things like that. So that's really relevant to us because herb wise, those are going to be the kinds of medications where we have to be really cautious and probably just don't prescribe herbs if we know that somebody's on a drug that has a narrow therapeutic index. Comps is again more about the broad concept, not necessarily about asking about individual drugs. So don't worry too much about the individual drugs yet, but just the concept of the therapeutic index. Mm-hmm. Along the same lines, there's the concept of protein binding. So remember, fat soluble substances can't dissolve in the blood because the blood is mostly water. And as we know, fat doesn't dissolve in water. You know, water and fat repel each other. So many fat soluble substances, in order to be transported in the blood, they have to be attached to plasma proteins. The proteins essentially act as carriers, and that includes fat soluble drugs. So if somebody's given a medication and it's a medication that's, you know, lipid soluble, that doesn't just dissolve into the blood by itself. It's carried on a plasma protein to essentially make it water soluble. And we have to be really careful with drugs that are highly protein bound. If a drug is highly protein bound, that means the person's protein levels are important because you need protein to carry the drug. So if the person is malnourished, for example, and they don't have enough protein in their body to make these plasma proteins, that can result in high levels of free drug rather than the drug being bound to protein. That can lead to problems. If the person has like kidney disease, for example, certain kidney diseases cause proteins to be lost in the urine. Same thing, that could affect drug levels if the drug is highly protein bound. So again, we have to be careful. We have to take that into account with the dosing and everything. And also, where again, it's relevant to us herb wise, is you have to be careful combining it with drugs or herbs that might compete for protein binding. Because what might happen is if you give another drug or you give herbs that compete for binding to a certain protein, it might displace some of this drug and result in too much free drug in the body. And that might lead to toxic effects. So again, you got to be careful with that kind of thing. So we, you know, as prescribers of herbs, If we know that a drug has a narrow therapeutic index and on the top of it, it also has high protein binding, it's a highly protein bound drug, then we even doubly have to be careful about giving herbs. And most of the time, what that means is we're just not going to give herbs unless, we're in contact with their primary care provider and, we've gotten expressed permission essentially that like, oh no, that herb is fine. But most of the time, medical practitioner like MDs don't know too much about our herbs, so that they're usually not going to risk it. They're just going to say no, don't do it. All right, so make sure you understand those general concepts. Fairly big picture. Like again, the questions on comps are not overly nitpicky about that, but you want to make sure you understand the general concept. Then there's some questions about in the test bank, there's some questions about whether or not a certain patient should get antibiotics, antifungal medication, or antiviral medication. So basically, what this question is, it might be framed as a pharmacology question, but in some ways, it's kind of a pathophys question too, because it's basically asking if you know whether a certain infection is bacterial, fungal, or viral. So these kinds of things, it could be asked more like a pathophys question, just a simple, straightforward, is gonorrhea bacterial, fungal, viral, or parasitic? And you would want to know that it's bacterial. Or they could frame it as kind of a pharmacology question and say, a person with gonorrhea should receive which of the following? And you'd have to know, like, okay, it's antibiotics. So what I did for each of these is listed some key things that fall under each umbrella. So bacterial infections that call for antibiotics, anything with the word strep, staph, whether it's streptococcus, staphylococcus, streptobacillus, like you see strep or staph, bacterial. Various STDs, gonorrhea, chlamydia, syphilis, all bacterial, impetigo, bacterial. Lyme disease is a bacterial infection, at least that's causing it. Like the Lyme disease itself is complications, but like it all originates from a bacterial infection. TB, bacterial. Tetanus, there's vaccines for it, so we don't really see too many people with tetanus nowadays, but tetanus is triggered by a bacterial infection. All right, so you want to know all those things are bacterial. There is one complicate or one what's the word, contraindication that you want to know. I've seen this question come up in the test bank that there is a category of antibiotics called tricyclic antibiotics that are contraindicated in pregnancy. Right. Fungal infection. Again, they can give you the more technical terms or they can give you the more lay people terms. So I've included both in here. So, like whether they use the term ringworm, which is more of a layperson's term, or tinea, which is the more technical term, those are fungal skin infections. So they need antifungal medication, not neosporin, not antibiotics. They need antifungal sprays and creams. Yeast infections, fungal. Molds. So when somebody has like mold in their home and they get sick, they get upper respiratory infections because they're breathing in the spores from the mold. Fungal. Candidas, fungal. Athlete's foot, jock itch, those are types of tinea. Those are just the layperson's terms. Those are types of tinea. That's fungal. Diaper rash, thrush. So thrush is where they get that like thick white coating on the tongue, all fungal. Then viral, common cold, influenza, COVID, STDs like herpes, but that could also include cold sores, viral. HPV, hopefully that's somewhat obvious because the V stands for virus, but this is the virus that causes warts and can increase the risk of cervical cancer. Again, virus. Hepatitis, hepatitis A, B, C, viral. HIV, which unmanaged HIV could lead to AIDS, viral infection. All right. And then last couple of things for anxiety, there's obviously lots of medications nowadays that are given, but for the purpose of the P specific college test bank, make sure you know benzodiazepines as the representative category of drugs for anxiety. And again, even though there's other options, for the purpose of the COMPS test bank, make sure you know selective serotonin reuptake inhibitors, SSRIs, are sort of the representative medication for depression. The idea is by blocking by inhibiting the reuptake channels, you're allowing the serotonin to build up in the synaptic cleft. By preventing its reuptake, it builds up more in the synaptic cleft, and that can boost mood. That can boost the person's energy, their mood, their outlook, etc. So, for comp purposes, those are some key things to make sure that you know. All right. All right. So that wraps up this handout. The next thing to get to is the endocrine system. A lot of potential questions. You never know, again, which ones are going to actually come up on the exam, but there's a lot of potential questions in the endocrine system. Now, some of this stuff will overlap with first year comps. First year comps, you had to know the glands, you had to know the hormones that the glands produce. You needed to know this is what the hormones do. So you still need to know that for second year comps, but now in addition, you also need to know the endocrine disorders. You need to know the things like diabetes and Graves' disease and Cushing's syndrome and Addison's disease and so on. So we'll go through that kind of stuff. We'll do a recap of all of the anatomy stuff too, but we'll highlight the disorders. First off, there are a few categories that sometimes get asked about, like just very general questions about various types of secretions in the body. So there's three general categories that might come up on the exam: paracrine, exocrine, endocrine. Paracrine is basically when it just has a local effect. So something gets released by a cell, some kind of chemical gets released by a cell and basically just communicates with the surrounding cells. It doesn't have a systemic effect. It just communicates with the surrounding cells. So, for example, like certain inflammatory chemicals might do that. Like if a cell gets injured and it's trying to activate a local immune response, those kinds of chemicals might qualify under paracrine. The key thing is just that it's a local response that it's triggering as opposed to, creating some kind of systemic effect. Exocrine, remember, exo implies like exit, outside, exterior, that kind of thing. So these are the secretions that we're releasing to the exterior of the body: sweat, tears, saliva. And those are pretty obvious, but the others that sometimes people confuse these, digestive enzymes, mucus, things like that, are also included under exocrine secretions. So remember that your GI tract, the inside of your GI tract, the lumen, that hollow space in the middle of your GI, that's actually considered to be the exterior of the body because it opens to the exterior. So your body is like kind of like a donut, right? You've got all this tissue, all this mass of tissue, and then you've got this hollow tube that runs down the middle, starting in your mouth, going down to your anus. If something is just in that hollow tube, that's considered to be the outside of the body. It's not part of your body tissues, in other words. So that's why digestive enzymes are considered to be exocrine secretions. And then endocrine, those are the chemicals, generally we refer to them as hormones, that various glands secrete and they're released into the bloodstream. And then they circulate throughout the bloodstream and they generally have some kind of systemic effect. Like raising metabolic rate or increasing cardiac output or various things like that. They generally have some kind of systemic effect. So the key thing with endocrine is these are things that are going into the bloodstream. Now let's go into some of the glands that are considered to be primary endocrine glands. The first one, sort of at the top of the hierarchy, we've got the hypothalamus. Now, the hypothalamus is a gland in what we call the diencephalon of the brain. So you might recall you have your two cerebral hemispheres connected by that corpus callosum. And then, kind of in the core, you have an area called the diencephalon. And within the diencephalon, you've got things like the hypothalamus, as well as the thalamus, and various other structures. And the hypothalamus is considered to be the master gland of the endocrine system because ultimately a lot of the other endocrine function is under the guidance, under the management, if you will, of the hypothalamus. The hypothalamus kind of runs it all. And the hypothalamus is actually also part nervous tissue. I mean, it is in the brain after all. So this is sort of like the hypothalamus kind of represents the overlap and the connection between nervous system regulation and endocrine regulation. Because you may recall the hypothalamus has neurons in it that regulate body temperature. So it could do things like activate sweating, for example, to cool the body off, trigger involuntary contractions that we call shivering in order to warm you up. The hypothalamus regulates a lot of that. There's neurons in there that when activated, it creates that subjective sensation of hunger or thirst. It also plays a role in various emotions. So there's a nervous system component of the hypothalamus, but then the hypothalamus also makes the hormones that activate a variety of other endocrine glands. So hypothalamus does a lot. Yeah. Has a lot of nervous system function, and it ultimately is what activates a number of other glands in the body, another number of other endocrine glands, hence this idea of it being the master endocrine gland. Now, the good news with the hypothalamus is you often don't really have to memorize the names of the hormones the hypothalamus makes because the hormones the hypothalamus makes all have the word releasing or inhibiting in the name, with a couple exceptions we'll get to in a minute, but they all have the word releasing or inhibiting in the name. So, for example, thyrotropic releasing hormone, this signals the thyroid gland to make thyroid stimulating hormone. It's basically telling another gland to release something. And then there's hormones that tell glands to stop releasing something. Those would have the word inhibiting in the name instead of releasing in the name. So essentially, whenever you see releasing or inhibiting in a hormone name, that's a hypothalamus hormone. So yeah, most of the hypothalamus hormones don't really do anything in and of themselves other than tell another gland to release something. So again, it's more of a managerial role. But there's a couple exceptions there. So the next gland in the hierarchy is the pituitary gland, found right near the hypothalamus. You might recall the pituitary gland is just inferior to the hypothalamus, also in the diencephalon of the brain. And you might recall that the pituitary gland can be divided into two lobes, the anterior lobe, which we often call the anterior pituitary, and the posterior lobe, that we often call the posterior pituitary. Now, you might recall the posterior pituitary has a little bit of nuance to it. The posterior pituitary does not make any hormones, but it does receive hormones from the hypothalamus, stores those hormones, and then releases those hormones into the blood when the hypothalamus signals it to do so. So the posterior pituitary is kind of like the gallbladder when it comes to bile. The liver makes the bile, the gallbladder stores it, and then the gallbladder pumps it into the duodenum when it's needed. Here, it's a similar kind of thing. The hypothalamus makes these hormones. The two hormones that are relevant here are ADH, antidiuretic hormone, and oxytocin. The hypothalamus makes those, sends them down little ducts to the posterior pituitary where they're stored, and then the posterior pituitary will release them into the bloodstream when they're needed. So if you get any questions on those, it's not a trick question. Just go with what's asked. If they're asking what gland makes ADH or makes oxytocin, the answer is the hypothalamus. It's not a trick question. The hypothalamus makes those hormones. That's it, period. Just like the liver makes bile. But if they ask you about the storing of those hormones and the releasing into the bloodstream, that's the posterior pituitary that does that for both of those hormones. All right. And that's it. Period. Done. That's all that is. Then, of course, the question comes up, well, what do those hormones do? So, antidiuretic hormone, it's right in the name. It's going to cause us to conserve more water. It's going to cause us to urinate out less water, hold on to more water rather than urinating it out. Specifically, it's going to signal the nephrons, and you can even get more specific. You can say it signals the collecting ducts, which is part of the whole nephron system. It's going to signal them to reabsorb more water. That's a more technical way of putting it. It signals the collecting ducts to reabsorb more water. So it'll cause more water channels to be opened in those collecting ducts. Therefore, more water gets reabsorbed rather than going out in the urine. And therefore, we conserve our fluids. We hold on to more fluids. This is typically triggered by two possibilities. This is triggered when the osmolarity of body fluids becomes too concentrated. So, in other words, if there's not enough water relative to solutes, our body fluids are too concentrated, that will trigger ADH release. And it also could be triggered from a drop in blood volume. If the overall amount of our blood volume declines, that could also trigger us to hold on to more water in order to maintain that blood volume. Mm-hmm. And again, you want to make sure you understand this. Like you're not just memorizing words on a paper, because sometimes when people don't fully understand, that's where the phrase, you always hear this from people sometimes, it's like I know it, but it's the way they phrased it. And most of there's always obviously some occasions where something was maybe not phrased well. Like everybody's human, including people that write test questions. So there can definitely be times where something wasn't phrased perfectly, but most of the time when somebody complains about that and you look at the question, it's like, no, it's really their understanding that's off. Like it's just sometimes a question might be phrased very precisely and particularly, and sometimes it's phrased a little more big picture. Like sometimes it talks about like the collecting ducts or something. Sometimes it talks about the nephrons. Well, the collecting ducts are part of that. Or sometimes it might just say the kidneys. And, you have to know, well, like, yeah, the nephrons are part of the kidneys. So sometimes things are just phrased a little more big picture. Sometimes they're phrased a little more precisely. But if you understand the general topic, I mean, you'll have no problem answering the questions. Now, as far as a pathology that's relevant here, diabetes insipidus. This is a condition where the person is not producing ADH. And without ADH, essentially the opposite's going to happen. Instead of conserving water, they're going to urinate copiously. They're going to over urinate. So during times where maybe they should be conserving, they're urinating copiously. That's going to lead to them becoming very thirsty, very dehydrated, could lead to drops in blood volume because they're losing all this fluid from their blood. This is what we call diabetes insipidus. Now, remember, a key thing here, make sure you don't confuse this with diabetes mellitus. This has nothing to do with blood sugar. So even though the name diabetes is in this is a different type of diabetes. This has nothing to do with blood sugar. If you were to test this person's blood sugar, their blood sugar is normal. This has nothing to do with insulin, nothing to do with blood sugar, nothing to do with diet, completely different condition. Then oxytocin, the other hormone, this is the hormone that we kind of think of as being the cuddle hormone, the love hormone, helps you connect. But it does also have some like more precise functions because that's a little bit nebulous. But It also promotes contraction of smooth muscle in the mammary glands to promote ejection of breast milk. And it causes uterine contractions to help facilitate delivery. So it's a lot of stuff having to do with babies. It kind of makes sense that like the lovey, cuddle, all that stuff kind of goes with that. You just had a baby, it's a painful experience, but you still love this little creature in front of you. So, like, this hormone is flushing through the body, helping to facilitate delivery, helping for the feeding process after, and also making you feel connected. Now, notice I highlighted the word eject because there's a separate hormone, prolactin, that promotes the making of breast milk. So you do want to make sure that you have that distinction down. Oxytocin is about making the smooth muscle contract to help push the milk out. Prolactin actually stimulates the glands, they like the endocrine glands that actually make the milk. Or sorry, I said endocrine, the exocrine glands that actually make the milk. And there's not really a disorder associated with oxytocin. I mean, at least not something that's a major disorder for comps. I mean, obviously, in theory, you could have excess or deficiency of any hormone. And if somebody had deficiency of oxytocin, it might affect their connecting to other people and things like that. But it's not like a major common disorder that would be on the comps. So nothing to worry about there. Then we have the anterior pituitary. Now, there's no more nuance for this one. Like the anterior pituitary, everything that we have listed under anterior pituitary is made by the anterior pituitary gland and directly released into circulation. So there's no more nuance about something making versus storing. That's only the posterior pituitary stuff. Everything else from this point forward, it's just the gland that we're talking about makes and releases the hormone. But there are a lot of hormones made by the anterior pituitary. And there is a little acronym for remembering them. It's not a very good one because there's only one vowel, but the first letters of each spell out flat PG. Again, not a very good one because that's not a real word, but with only one vowel, there's only so much you can do. So flat PG. And that stands for follicle stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, thyroid stimulating hormone, prolactin, and then finally growth hormone. So there are 6 hormones produced and released into circulation by the anterior pituitary gland. So this one, make sure you remember, because there's a lot that come from there. Now, as far as what they do, and if there's any disorders associated with them, follicle stimulating hormone, this is all about reproduction. It basically stimulates sperm and oocyte production. So as ultimately, it's going to regulate, sperm count, and it's going to regulate, the development of the oocytes in the ovaries. Now, again, of course, there can be a pathology where somebody's deficient in this and therefore they would get a low sperm count. Maybe their oocytes want to develop properly and so on. Again, somebody could have an imbalance here, but there's not like a common disorder with a name that you have to worry about for comps. Just know what the hormone does. Luteinizing hormone. The big thing with this one, it does have an effect on regulating testosterone production. So there is that effect. But the thing that tends to come up most commonly about luteinizing hormone is that midway of the female reproductive cycle, typically on average about day 14, but it doesn't have to be exactly day 14, there's a surge in luteinizing hormone, and that's what triggers ovulation. That is a very common question. It's definitely in the test bank. Don't know if it'll come up, but that is a very common question. Luteinizing hormone triggers ovulation. And this is one you just want to make sure that you absolutely know without question, because there's a lot of other hormones that you might start to second guess if you don't just know this for a fact. Like let's say they asked you what hormone triggers ovulation. What if estrogen was put as an option? What if follicle stimulating hormone was listed as an option? What if progesterone was listed as an option? Or testosterone, even? People might fall for some of those answers. They might go, I don't know. I mean, I thought it was luteinizing hormone, but I don't know. Like now I'm second guessing myself. So that's why it's like you want to just know this. You go in, you know it for a fact, and then you don't second guess yourself. Because that's another thing that I hear sometimes. And I'm not trying to like, talk badly about any students that are in this position. I understand there's stress associated with taking these tests and stuff, and I get it. But this is the reason why you want to study as much as possible. So you just like know what you know and you trust what you know. Because another thing I hear from students is like, well, no, I know this stuff, but it was the options they provided. It made me second guess. And it's like, well, the other options were just wrong options. Like, yeah, you second guessed yourself, but that's because you didn't like know it firmly enough, so you second guessed. But those other options were just wrong options. It wasn't a legitimate answer, so like, yeah, estrogen would just be a wrong option. Luteinizing hormone is the correct answer, period. Number three here, adrenocorticotropic hormone, ACTH for short. This one, it's right in the name exactly what it does. Adrenocortico. So it's telling you this stimulates the adrenal cortex. And specifically, it stimulates the adrenal cortex to release cortisol. So it's all right in the name what it does. And honestly, I have seen a question come up on comps, like in other words, it's in the test bank, asking exactly this. What does adrenocorticotropic hormone do? And I've seen people select answers like it stimulates the thyroid gland or something like that. Now, I have to think that's a situation of people going, well, it can't be the adrenals. That's too obvious. Again, it's one thing if you know an answer to be something else. Like if you know that, oh, this one has a weird name, it's tricky, and you kind of know that this one's the opposite of what you would think. But if you're making a guess, go with what looks obviously correct because there's so many questions in the test bank where like the obvious answer is the correct answer. You almost question like, God, I can't believe they put that in the test. Like, that's so obvious. But I think it's done purposefully because they know students who don't really know the material well, they're going to say to themselves, well, that's too obvious. It can't be that. And then they're going to go with something else. So again, this is exactly what it sounds like. Now, there is a disorder where there might be a tumor that's producing too much ACTH. So that leads to the adrenal glands to make excessive amounts of cortisol. That's what we call Cushing syndrome. And remember what cortisol does. Cortisol causes us to essentially break down tissue in order to get raw materials to raise glucose levels, to raise blood glucose levels. Now, if everything's working normally, this typically happens in fight or flight. When we're in an emergency mode, we produce more cortisol. That stimulates breakdown of things like muscle tissue and fat. We then get the raw materials to make more glucose. And the idea is then that glucose helps fuel ATP production so we can run away, fight off an emergency. Here, we're pathologically producing too much cortisol. Like there's not actually an emergency. We're not actually burning the calories. We're just making excessive amounts of cortisol that's leading to excessive tissue breakdown and excessive glucose production. And then when we don't actually use the glucose for ATP, the body restores it. It reconverts it to fat and restores it. So we end up getting kind of like basically the main sign symptom of this is a redistribution of fat. So the person tends to start getting breakdown in the extremities. They get what they refer to as wasting extremities. And then we tend to redeposit more of this stuff in the core. So the way cortisol works is it tends to rob more from the extremities. And then when we don't actually burn the glucose and we ultimately restore it, we tend to convert it into fat and restore it more in the trunk. So the person gets these wasting extremities, these sort of atrophied extremities, and then they get truncal obesity, big belly. They get a big rounded face. It's all fat accumulation. Sometimes it's referred to as a moon face because it looks full and circular. They might get fat deposits on the upper back. Sometimes that's referred to as a buffalo hump type of appearance. They have hyperglycemia because, again, this is raising blood sugar ultimately. They get high blood pressure because of all that sugar in the blood. And again, they're breaking down peripheral tissues. So the long term consequence of this is the person might get thinning of the skin, osteoporosis, muscle atrophy. They get stretch marks because of all that rapid fat accumulation in certain areas combined with thinning of the skin. So that's how Cushing syndrome might present. So think C for cortisol, C for Cushing. You could also think Cushing, the person has a lot of extra cushion because they get more fat accumulation around the trunk. So you might think of that as like cushioning, just as a way of remembering it. So that's your Cushing syndrome there. Then we have thyroid stimulating hormone. This is a simple one because it just says exactly what it does. This hormone basically just goes to the thyroid gland, which is located here around the trachea, and it stimulates the thyroid gland to make more thyroid hormone. And the thyroid hormones are T3 and T4. You could specify them by name, T3 and T4. Technically, there's a more technical name, triiodothyronine and thyroxine, but most of the time it's abbreviated T3 and T4. And oftentimes those are just collectively referred to as thyroid hormone. So this hormone stimulates the production of these hormones. Then you have prolactin. We already mentioned that promotes the making of breast milk. Again, don't confuse that with oxytocin, which promotes the ejection of breast milk. And there is a disorder, and it's actually a relatively common endocrine disorder involving prolactin. You might hear it referred to as a prolactinoma, or you may hear it referred to as hyperprolactinemia. The two are not mutually exclusive. It's just you might hear referred to either way. The reason you might hear it called a prolactinoma is because most commonly it's a tumor on the pituitary gland that's producing the prolactin. So, in other words, they have a prolactin producing tumor, a prolactinoma. And that causes excess prolactin in the blood, which we might call hyperprolactinemia. So, these two things aren't mutually exclusive. They're just terms that you might hear associated with this condition. It could go really by either. And if somebody has excess prolactin in the blood, in females, that usually causes galactorrhea, abnormal lactation. In other words, they didn't even have a baby, but they start lactating. Abnormal lactation. That's kind of the main sign in females because remember, female breast tissue is more prepped for breasts for producing milk. Male breast tissue, it's not as developed. So in females, you would tend to see galactorrhea as a primary sign. In males, you tend to see gynecomastia, where essentially their breast tissue starts becoming more developed. So they actually start to show some development of breast tissue. That's what we call gynecomastia. And the buildup of excessive prolactin can suppress some of the other reproductive functions. Essentially, high levels of prolactin sort of trick the body into thinking like it's pregnant or that the person just had a baby. Because under normal circumstances, why else would prolactin levels be so high? So this can cause things like amenorrhea, lack of ovulation, which would lead to infertility. In males, it can lead to things like impotence, erectile dysfunction. So it can interfere with some of those processes. And headache, that can come with any pituitary tumor. Keep in mind, this is generally due to a tumor on the pituitary. So if somebody has a tumor on their pituitary, certainly headache could be a sign. So I mentioned that. So don't let that throw you off if they mention headache. Yeah, it's a pituitary tumor. So of course they could have that. Then we have growth hormone. And one thing about the growth hormone is you want to remember that a lot of the musculoskeletal tissue in the body doesn't respond directly to growth hormone. The pituitary, anterior pituitary, releases growth hormone into circulation. And a good chunk of that is picked up by the liver. And the liver will convert that growth hormone into something we call insulin like growth factor 1, or IGF-1 for short. And then a lot of the musculoskeletal cells respond to the IGF-1. And it basically triggers those musculoskeletal cells to make more proteins, undergo more cell division, and therefore leads to growth. So just make sure that you know that if something is mentioned about insulin like growth factor 1, that that's related to growth hormone, that the two kind of go hand in hand. Now, there's a couple disorders that are associated with this. Pituitary dwarfism. This is where there is a lack of growth hormone, and by extension, a lack of insulin like growth factor 1, and the person just doesn't grow. The musculoskeletal tissue doesn't get stimulus to grow, and it leads to a person who is much below average height, based on like the averages for that group of people, based on, sex, genetics, etc. They're well below average height. But one thing about pituitary dwarfism is their limbs, their torso, their head, like it's all proportional. Everything is equally not receiving the signal to grow. So it's all proportional. They're just smaller. Everything is proportionally smaller to what they otherwise would have hit if it weren't for this disorder. The reason we point that out is you might recall that there's another disorder, a genetic disorder called acromegaly. I'm sorry, I'm looking at the page, not acromegaly, achondroplasia. And that's a genetic defect of cartilage. And that disproportionately affects the growth plates and long bones. So people with achondroplasia, they're disproportionately short. Like they're short, they're smaller than that they would be outside of this condition, but it's disproportional. The limbs are extra short relative to the torso, relative to the head. Whereas pituitary dwarfism is all proportional. So sometimes that distinction can come up. Pituitary gigantism, this is the opposite. This is just excess growth hormone. So typically the person would grow to great heights. Acromegaly is sort of an offshoot of gigantism. Acromegaly is also caused by excess growth hormone, but acromegaly more refers to bony deformities, not the person's height. So somebody with acromegaly, they have things like protracted jaws, they have like lumps and bumps on their bones. They might have like thickening of the lips, thickening of the bridge of the nose. Like there's some bony deformities associated with this. Now, they're not mutually exclusive. Somebody can have gigantism and acromegaly. So, in other words, if this is something they've had for many years, prior to hitting their starting prior to their bones fusing, like say it started in puberty or something, they can grow to huge heights and develop bony deformities. But there are some people that they might get a growth hormone producing tumor starting at the age of 55. Well, those people, they're not going to start growing vertically at that point because their growth plates have already fused and everything. So they can no longer grow vertically, but they might get thickening of the bones at that point. And that person, therefore, would have acromegaly, but they wouldn't have gigantism. So again, they're not mutually exclusive. Somebody could have both, but it is possible to have one and not the other. So that's why they separate these things out as two different conditions, even though they're related. All right. And then also in the brain, we have the pineal gland, also in the diencephalon of the brain. So it's kind of nearby the hypothalamus and the pituitary gland. And the only thing you have to really know about this one is it makes melatonin. And melatonin, of course, is known for regulating our sleep wake cycles, otherwise known as our circadian rhythm. So, generally speaking, more melatonin makes us sleepy. Usually melatonin production is triggered by when it starts to get dark. But we know now, like modern society, like we're all kind of messed up in that department because of artificial light and everything. So, there can be a lot of disruption with this. But again, comps isn't going to get into like all that. It does comps doesn't get into anything that's like sort of nebulous and vague and like, oh, I've heard this or heard that. It's just going to stick with like the facts. So I mean, for comp purposes, just know pineal gland located diencephalon of the brain makes melatonin. Melatonin is known for regulating sleep wake cycles. It's not going to get into like all the many things you may have heard or this or that. All right. So that is a good breaking point. I know there's nobody here, but I need to rest my voice and use bathroom and stuff like that, get some water. So I will take a 10-minute break and I'm going to leave the recording going so I don't accidentally forget to turn it back on. So you could just jump forward 10 minutes if you're watching the recording. So take 10 minutes and pick up here. All right, y'all, let's continue. All right, so now we go to the thyroid gland. Thyroid gland, remember, of course, is located around the trachea down here. And the thyroid gland is going to produce two groups of hormones. So one is what we usually just call thyroid hormone. I mean, technically, all these hormones are thyroid hormones that come from the thyroid, but generally, when we just use the expression thyroid hormone, we're referring to the T3 and the T4. And those are the hormones that regulate the metabolic rate. And the metabolic rate, meaning essentially the rate at which we convert food into ATP. Now, there's a couple of disorders that come up with this. There's essentially hyperthyroidism and hypothyroidism. And the two main examples, now keep in mind, there's lots of things that can cause hyperthyroidism or hypothyroidism. I mean, a simple example is somebody could be born without a thyroid. But the two primary disorders that tend to come up on some like a comp exam, like the biggies, are Graves' disease for hyperthyroidism and Hashimoto's thyroiditis for hypothyroidism. So remember the mechanism of Graves' disease. There's autoantibodies that stimulate the thyroid gland. So it's an autoimmune disorder. The person makes these abnormal antibodies, but these antibodies are a little bit different than what a lot of autoantibodies do. You know, usually when you think of autoimmune disorders, you typically think of autoantibodies reacting with a tissue and creating damage to that tissue. You know, usually it triggers an inflammatory reaction and leads to damage to that tissue. But these particular antibodies, they're shaped in such a way that they actually resemble TSH. They kind of look like thyroid stimulating hormone chemically. And so they actually stimulate the TSH receptors, the thyroid stimulating hormone receptors on the thyroid gland. And it therefore triggers the thyroid to produce huge amounts of thyroid hormone. And that causes the person's metabolic rate to go through the roof. They start converting food calories into ATP very rapidly. So they're not really storing any calories, they're just turning everything into ATP. So that creates things like extreme weight loss. Their body fat percentage gets very low. So that can lead to things like amenorrhea if it's somebody that otherwise would be menstruating. You know, extreme drops in body fat can suppress menses. It leads to the person being, you know, hot body temperature wise because they're carrying out a lot of those metabolic reactions that create heat. So they get sweating. They have all this extra energy, so they can't really sleep at night. You know, insomnia, nervous, anxiety, racing heart, high blood pressure, you know, all that kind of stuff going on. And one of the really standout signs, like just to look at the person, you kind of see that, oh, something is up, is they get what they call exophthalmos, which are bulging eyeballs. The eyeballs kind of bulge out. And that's because the little muscles in the eye get a little bit swollen and enlarged and essentially push the eyeballs forward. Make sure that you know the term exophthalmos and that you know to associate that with hyperthyroidism or Graves' disease, which is the most common cause of hyperthyroidism. Mm-hmm. Then you have the opposite scenario. You have Hashimoto's thyroiditis, or sometimes just called Hashimoto's disease. Here, it's also an autoimmune disorder, but in this case, the autoantibodies are reacting like, you know, more the way we typically commonly think of autoantibodies behaving. They're reacting with the thyroid gland, triggering inflammation, and ultimately destroying the thyroid gland. So a little more like how we typically think of autoimmune diseases working. So it's causing damage to the thyroid gland over time. So eventually the person gets to the point where they're not producing thyroid hormone. They're producing very minimal amounts or none at all, perhaps. And so now we have the opposite of Graves' disease. Their metabolic rate goes into decline. So they're gaining weight. You know, rather than converting calories into ATP, they're storing all of this. You know, all the food they're eating, they're storing, and they're only making minimal amounts of ATP. So they're getting weight gain. They're not running as many of those ATP generating reactions. So they get cold in temperature. their heart rate slows down and everything kind of slows down. They get bradycardia. So that leads to poor circulation. That's why they get the things like the dry skin, the dry eyes, the thinning of the hair, edema. Circulation slows down. So they're getting kind of a backup of circulation leading to the edema, and they're not pumping blood effectively to their tissues. So that's why certain tissues like the skin, the hair kind of get sacrificed. They're very sleepy, very fatigued. That's really the hallmark of this condition is like very low energy. Low energy. So make sure you know the key things about these two disorders. Now, calcitonin, also produced by the thyroid gland, the reason I highlighted it is not because calcitonin is the most important hormone or anything, but it's just one of those ones that people commonly forget what gland makes it. I've had that come up so many times in class where like calcitonin has maybe come up in class. And this is at a point like someone like AP4, where students have already learned, the endocrine system. And I'll just kind of ask, like, as a reminder, like, all right, who remembers what gland produces calcitonin? And I'll get every answer other than the thyroid. So make sure you know thyroid gland produces this. And the name calcitonin, though, does give you a clue as to what it does. With the name calc, kind of implies as something to do with calcium. And that is true. So this hormone promotes the bones to uptake more calcium from the bloodstream. It's essentially a signal to the bones that, like, all right, there's plenty of calcium to go around. So bones, you can uptake that calcium, and it leads to stronger, thicker, bones. So sometimes people remember calcitonin tones the bones. I mean, kind of a made up expression. Like, what does it mean to tone the bones? But most people kind of get what that means. And by extension, by the bones uptaking more calcium, it's causing lower calcium levels in the blood. So another way of phrasing this is we could say that calcitonin lowers the amount of calcium in the blood. And so some osteoporosis medications are basically synthetic versions of calcitonin. So somebody with osteoporosis might be given medications that are basically the same chemical structure as calcitonin, just synthetically generated. Right. Then we have the parathyroid gland. And that's really four little glands on the posterior aspect of the thyroid. And make sure one thing to be clear about, because again, anytime I emphasize certain things, it's because I've seen so many people make these kinds of mistakes. So I try to emphasize it when I'm teaching these review classes. Make sure you're clear that the parathyroid is considered to be separate and distinct from the thyroid. I've definitely had it happen where I've been in the classroom, proctoring back when the exam was physically on campus. And people would come up to me like, oh, aren't there two right answers here? Because like one answer said thyroid and the other said parathyroid. Make sure that you're clear that they are considered separate and distinct. So, in other words, you would not say that the parathyroid gland makes calcitonin, and you would not say that the thyroid gland makes parathyroid hormone. They're separate and distinct. So the parathyroid gland is four little glands really on the posterior side of the thyroid. It produces one hormone, aptly named parathyroid hormone. And parathyroid hormone does the opposite of calcitonin. It promotes bone breakdown in order to put more calcium in the blood. So you could phrase it either way. It promotes bone breakdown. You could also say it raises blood calcium levels. Now, you might think at first glimpse, like bone breakdown. Oh my God, that sounds horrible. But most of the time, we're just talking like very microscopic amounts just in order to maintain a certain level of calcium in the blood. Because remember, we need a certain amount of calcium ions in the blood and body fluids because they're critical for regulating action potentials and muscle contractions. They're an important electrolyte for those kinds of things. So you need to have a certain amount of calcium in the blood at any given moment. And so this is how we regulate that. Again, separate from the thyroid. So don't fall for a wrong option that says the parathyroid gland, if you get a question about what the parathyroid gland does, don't fall for a wrong option that says regulates metabolism. Again, it's separate from the thyroid. Now, there is a disorder, hyperparathyroidism. And so in this case, typically there's a tumor on one of the four little parathyroid glands. There's typically a tumor that's producing excessive amounts of parathyroid hormone. And since there's excessive amounts of parathyroid hormone, what that winds up doing is excessively breaking down the bones and excessively causing calcium to build up in the blood. So it takes what parathyroid hormone does and brings it to an excess. And this is the one you may recall from a pathophys class. This is the one that has some rhyming signs and symptoms. Sometimes people will describe this as bones, stones, moans, groans with fatigue overtones. So the bones refers to bone breakdown. It's triggering bone breakdown. So they're developing bone pain. They're maybe getting pathological fractures where their bones break easily. A very minor injury causes their bone to fracture. Calcium levels are now building up in the blood, and that increases the likelihood of kidney stones because when the kidneys filter the calcium, though that huge abundance of calcium sometimes clumps together, creating kidney stones. The moans, well, kidney stones cause a lot of pain. So, symptom wise, the person might be in a lot of pain. That's where the moans come in. Groans is all that calcium in the blood thickens the blood. And so that can impair circulation, including circulation of the brain. So the person tends to kind of feel very lethargic, fatigued, depressed. So that's kind of where the groans and fatigue overtones come into this. And then there's one thing that doesn't really fit the symptom picture, or sorry, it doesn't fit the rhyming, but it is a common sign of hyperparathyroidism, and that's tachycardia. You may recall that calcium is what rushes into the SA node to cause a depolarization. So if there's huge amounts of calcium in the extracellular fluid, then it's going to rush in faster and it's going to lead to a more rapid heart rate. So not one of the not one, it doesn't really fit with the rhyming, but it is one thing that we should include here. So that's hyperparathyroidism. All right. Then we go to the pancreas. And the pancreas is one to make sure that you know pretty well because there are a lot of questions potentially about insulin and diabetes and things like that. Again, you never really know which ones will actually come up on an exam, but there are definitely things in the test bank about this. So you want to make sure that you know how these hormones and how they work. So within the pancreas, there's a cluster of cells collectively referred to as the islets of Langerhans. And these islet cells, sometimes they're just abbreviated islet cells, sometimes the whole thing is spelled out. This cluster of cells makes two hormones, insulin and glucagon. And insulin and glucagon, hold on, I'm gonna sneeze. All right, well, it went away. So you have insulin and glucagon. Those, remember, have opposing actions. So insulin lowers blood sugar, or you could say blood glucose. So typically after a meal, you'll absorb whatever you digested. And so assuming there's some carbohydrate in the meal, you would absorb glucose into the blood. And there would be a brief spike in blood sugar at that point. That would trigger insulin release. That will trigger the islet cells in the pancreas to release insulin. And then insulin promotes our cells to uptake that glucose to either use it to make ATP in some cases or to store it for use at a later time. So it causes the cells collectively to sort of uptake glucose. Some of them will use that glucose for ATP. The liver and muscles might store that glucose in the form of glycogen. Remember that glycogen is stored glucose, and the liver and the muscles are the two primary tissues to do that. You may recall that the muscles store it for their own benefit, where the liver stores it for regulating the blood sugar as a whole. So the liver can store glycogen And then when blood sugar drops, the liver can break that glycogen down and release the glucose back into the blood in order to stabilize it. Muscles just use it for themselves. All right. So the making of glycogen, there's a term for that. We call that glycogenesis. So they might use that term. Make sure you know what that means. Genesis means to create. So glycogenesis means the creation of glycogen. And we might also convert some of that glucose into fat and store that in the adipose tissue. That creation of fat is what we call lipogenesis. Insulin will promote that as well. So insulin essentially promotes sugar to leave the bloodstream and to go into the cells, either to be used to make ATP or to be stored, either stored as glycogen or converted to fat and stored as fat. Insulin promotes those things. Now, disorder wise, there's what we call type 1 and type 2 diabetes mellitus. Type 1, remember, is typically an autoimmune disorder. Most commonly, it's an autoimmune disorder that damages the insulin producing cells in the pancreas. Basically, this autoimmune mechanism targets the insulin producing cells in the pancreas, and it creates a situation where the person can't produce adequate amounts of insulin. And they need insulin injections, in other words, from that point forward, in order to manage their blood glucose levels. Without insulin injections, their blood sugar goes through the roof. They develop what we call hyperglycemia. Their blood sugar goes through the roof, and the cells aren't able to effectively utilize glucose. So they need insulin injections in order to manage that. Type 2 diabetes mellitus, here it's more of an issue of cellular resistance. The pancreas in type 2 is still producing insulin. The problem is the cells no longer respond to it. The body cells basically aren't listening to the insulin. It's a cellular resistance issue. This can be managed with lifestyle, things like weight loss, exercise, because most commonly this disorder is associated with having a higher body fat percentage and low activity. So it's typically associated with eating more like high sugar processed foods that cause rapid spikes in blood sugar on a recurring basis. And then it's characterized by somebody who relatively speaking, has lower activity, more sedentary lifestyle. So they're not really utilizing that sugar. They don't really need to make more ATP. They're not engaged in a lot of vigorous activity. So they don't really need all that sugar they're taking in. And the body's already stored everything it could, so they usually already have a high body fat percentage. The glycogen stores are already full. So the idea is eventually the tissues get to the point where they just don't listen to the insulin anymore. It's like our glycogen stores are already full. We already have a lot of body fat stored in our adipose tissue. The cells are like, we already have plenty of ATP and we're not burning through it. So the cells stop responding to the insulin, and now the blood sugar starts to build up. But if the person changes lifestyle, if the person starts exercising more, well, now they're going to burn through some of their ATP, and then they will get to the point where they need to make more. They're going to start burning through more of their glycogen and get to that point. Okay, now we do need to replace some. So that's why this can potentially be managed with lifestyle modifications and such. So the underlying mechanism is a little different for type 1 versus type 2, but the signs and symptoms can definitely have some overlap. In both cases, the person would have hyperglycemia. And you may recall the three P's: polyuria, polydipsia, polyphagia. Polyuria, they're urinating copiously. The reason is that when the kidneys filter the blood, all that sugar that's being filtered out actually attracts water to follow it. And then they wind up urinating with sugar in the urine, which shouldn't be there. And more water is attracted to follow that sugar. So there's copious amounts of urination, polyuria. They're thirsty because they're urinating out so many fluids. So that's what we call polydipsia. And polyphagia is more common in type 1. That's excessive hunger. The thing with type 1 is the body's confused. Because the body's not producing insulin, the hunger center in the hypothalamus, the chemistry of the very, very low insulin is making the hunger center assume that you're starving to death. The cells aren't able to uptake adequate amounts of sugar. you know the fat storage is declining, the glycogen stores are getting low, the body thinks it's starving, and really it's not that they truly need more food or more sugar. It's just that the cells, because of the lack of insulin, can't utilize the sugar effectively. So they're getting these hunger cravings like they need to eat more, but really what they need is insulin. They get fat loss because since the body can't effectively utilize sugar and the body thinks they're very low in sugar because, again, no insulin. So the chemical signal a lot of these cells are getting is that, like, oh, there's no sugar available because, hey, we don't have any insulin. Why else wouldn't we have insulin? So they start breaking down more body fat. So they get like weight loss, they're hungry. Again, this is more common in type 1 because it's more linked to the low insulin levels. And then all this sugar building up in the blood increases the blood viscosity. That's a major complication with diabetes mellitus, is the blood viscosity increases because of all this sugar buildup, and that leads to really poor circulation. So that's the reason that people with diabetes mellitus, if it's not managed properly, the reason they could develop ulcerations, necrosis, or gangrene, wounds that don't heal, infections that just kind of get worse. Because keep in mind, with infections, bacteria, fungus, they're going to love all this sugar. They're going to thrive on all this sugar in the body fluids. So that's where a lot of the major complications come into play. Poor circulation and all that high sugar promoting what's the word I'm looking for? Allowing infectious material like bacteria, fungus to thrive. Right. So that's why diabetes can be so dangerous. Like, in some ways it sounds so simple, like, okay, high blood sugar. Don't really sound like that big of a deal, like on the face of it, on the surface. But when you consider all the complications of that, that's why it's such a problem. And then the other hormone made by the islets of Langerhans, remember, is glucagon. And glucagon does the opposite of insulin. If blood sugar is declining, so for example, the person's gone too long without a meal, their blood sugar is starting to decline, which makes sense. The cells are using the sugar that's available, so it's little by little declining. If the person doesn't eat right away, the glucagon will allow you to tap into your stored sugar. So glucagon will promote breakdown of glycogen, what we call glycogenolysis. And the liver can then put that glucose from the glycogen breakdown back into the blood in order to stabilize blood sugar. It can promote fat breakdown, lipolysis. And then the liver can convert that fat into sugar in order to get blood sugar back to normal. That's what we call gluconeogenesis, the creation of new glucose, gluconeogenesis. So when you convert something like fat or amino acids into glucose, which the liver is capable of doing, that's what we call gluconeogenesis. And glucagon promotes that. There's not really a specific disorder with the glucagon that we have to worry about. Insulin is more the more common one as far as disorders go. All right, and then lastly, for the endocrine system, we have the adrenal glands. The adrenal glands are located superior or on top of the kidneys. But again, just make sure you're clear, similar to what we're saying about the thyroid and parathyroid. The adrenal glands are their own separate, distinct thing. They're not considered to be part of the kidneys. And again, that's just something I see people do where, they'll select kidneys when the answer is adrenal glands or vice versa. Or they'll come up and say, aren't there two right answers here? So just be careful about that. The adrenal glands are divided into two general sections. So there's the core of the adrenal gland called the adrenal medulla that produces epinephrine. And remember, epinephrine basically just amplifies fight or flight response. It activates all of the same processes that you would think of sympathetic activation as activating. So, last class meeting, we went over sympathetic versus parasympathetic stimulation. Everything we associate with sympathetic, epinephrine basically stimulates all those same things. Then you have the adrenal cortex, and there's a couple categories of hormones that get produced by the adrenal cortex. There's really just like one primary hormone in humans that we have to know, but you want to make sure you know the category. That cortisol is an example of a glucocorticoid, because I have seen those terms used on the exam. So you want to know cortisol is a glucocorticoid hormone from the adrenal cortex. And we already mentioned cortisol under normal circumstances raises blood sugar during fight or flight, during stress. So the idea is when you're in fight or flight mode, the idea is you might have to run from an emergency, fight off an attacker. So you're probably going to need to burn through more sugar for ATP production than what's average. So as soon as you start kind of going into that fight or flight mode, it triggers cortisol release, which helps get the blood sugar up in anticipation of like having to run off or something. Then we have mineral corticoids. That's a type of hormone. The example that you need to know from human adrenal cortices is aldosterone. And aldosterone stimulates sodium reabsorption in the nephrons, or you could say in the collecting ducts. And if you release more, or if you reabsorb more sodium, that's going to draw more fluid out of your cells and into the extracellular fluid. Essentially it's a redistribution of body fluids, and that helps get the blood volume and blood pressure back up. Yeah. Now that's a normal managing of blood volume and blood pressure, but that mechanism is the reason that if you have a person that has hypertension already, you generally advise them to eat less salt in the diet, because one of the effects of having more salt in your blood and body fluids is it draws fluid out of the cells and puts more fluid into the extracellular compartments, including in the blood. And then that adds to the blood volume and blood pressure. So it's good to have this mechanism for periods of time where we need to get more fluid into the bloodstream. But if somebody already has hypertension, then you got to be careful with sodium. Now, the reason I highlighted sodium is notice here the description for aldosterone. It's almost identical to the description up here for antidiuretic hormone. The key difference is antidiuretic hormone causes water reabsorption, and aldosterone causes sodium reabsorption. Other than that, the description is basically exactly the same. So just make sure that you don't confuse those two. Androgens are a third category. That just means that we do get some of the raw materials from the adrenal glands to make testosterone and estrogens. I've not really seen too many questions come up regarding that, but it is a third category that comes from the adrenal cortex. The final endocrine disorder that you should know is Addison's disease. Addison's disease is, again, another autoimmune disorder. In this case, this autoimmune process targets the adrenal cortex. It destroys, damages the adrenal cortex. And if you damage the adrenal cortex, that means this person is not producing cortisol. They're not producing aldosterone. So if you think about what those hormones are supposed to do, and you're not producing those hormones, you're going to get the opposite effects. So with no cortisol, they're going to get hypoglycemia, particularly during periods of stress, because they're not going to get that boost in glucose to fuel that extra activity. So during those periods, their blood sugar is going to likely go down. It's going to drop too much because they're going to burn through more than what's there. And we've all probably experienced from time to time at least a slight hypoglycemic state. This happens sometimes if you're under a lot of stress and you go too long without eating and maybe you're caffeinated. You get to that place where you start getting a little nervous and, shaky. It's almost like a panic attack. You start sweating, you start getting tachycardia. The body basically goes into fight or flight mode because it's like, hey, we're starving to death. Our blood sugar's dropping. We're running out of the raw materials we need to make ATP. And it kind of puts you into that emergency mode and triggers that fight or flight panic attack type of state. So somebody with Addison's disease is very prone to that. And without aldosterone, they don't have a way of stabilizing their blood pressure and blood volume if they go too long without drinking water and things like that. So, if they start to get dehydrated, for example, because they're sweating and they're not replacing fluids, they don't have a mechanism of sort of stabilizing that blood volume. So they're going to get drops in pressure. That'll lead to things like dizziness, lightheadedness, fainting, etc. So those are some of the key problems of somebody with Addison's disease. And then the last thing here, endocrine wise, is you do get some questions about that renin, angiotensin, aldosterone cycle. First off, make sure you remember the big picture. The overall purpose of this is when this cycle gets triggered, the overall effect is it raises blood volume and blood pressure. So if somebody has some kind of drop in their blood volume and blood pressure for whatever reason, they're sweating too much, they're not drinking enough fluids, they're deficient, they don't have enough electrolytes, whatever the reason might be, if their blood volume or blood pressure starts dropping for some reason, could even be they have some internal bleeding or something, this mechanism will kick in to stabilize it. And it all starts with the kidneys secreting renin. The kidneys are essentially monitoring the blood flow they receive. And if they detect a drop in that blood flow, it triggers them to secrete renin. Then renin goes into the bloodstream and it reacts with an inactive enzyme called angiotensinogen. Angiotensinogen by itself doesn't really do anything. It's just an inactive enzyme. But when renin reacts with it, it converts it into angiotensin 1. Now, even angiotensin 1 by itself doesn't really do much. But now we have angiotensin 1 going through circulation and it's going to pass through the lungs because all blood ultimately passes through the lungs. And in the lungs, there's an enzyme called angiotensin converting enzyme, ACE for short. And ACE is going to convert angiotensin 1 into angiotensin 2. And now finally, angiotensin 2 triggers 4 things to happen. And collectively, all of those things are going to get the person's blood pressure and blood volume back up, hopefully stabilize it. So angiotensin 2 will trigger ADH and aldosterone release. So that will cause us to reabsorb more water in the kidneys, reabsorb more sodium. Both of those things will help get that blood volume back up. It'll trigger constriction of arterioles throughout the body. So if you make your blood vessels constrict, that should get the pressure up because now there's less space in the circulatory system. So that should boost pressure. And then lastly, it should activate the thirst center in the hypothalamus, making the person feel thirsty. And if somebody feels thirsty and there's fluid available, they're likely to drink, and that will also add to their blood volume as they absorb that water and everything. So that's essentially how this will work. So the collective effect of all this is increasing the blood volume and blood pressure, and it all starts with the kidneys' release of renin. And you may recall when we were talking about blood pressure medications, when we we're going over the cardiovascular system, we mentioned ACE inhibitors. The way ACE works is it basically deactivates this enzyme. Maybe not completely, like that's where dosing comes in. You don't necessarily want to completely deactivate it, but lessen its effects. So if somebody already has hypertension and you're trying to manage it, if you're trying to basically bring their blood pressure down, you want to negate some of this a little bit. And that's what ACE inhibitors will do. It'll block this enzyme, which will ultimately lead to lesser angiotensin 2 levels, and that will lead to lesser of these effects. And so, if everything else remains equal and you're getting lesser of those effects, that should bring the blood volume and blood pressure down. All right. So, that, everybody, is the endocrine handout. So, there's a lot of potential things there for questions. But again, when it comes to the comps, most of the comps are fairly big picture questions. It's knowing like just basic facts. It doesn't really get into a lot of nuance, a lot of nebulous concepts, a lot of things that you might have heard here and there. It just kind of sticks with the facts that there's like no debate about. This gland makes this hormone. This hormone does this thing. This disorder has these key symptoms. It just kind of sticks with those basics. So you don't have to be the most expert on all of this stuff in order to answer the questions right, but you do have to go through this and make sure you have a pretty good understanding of what's here. Okay. All right. So the next handout we're going to get to, and this is going to this will wrap up the, really the, almost the, just about the last section that we have to wrap up. This will wrap up the biomed stuff. And next class, we'll finish this because we probably won't get through all of this today. This is a long handout. We'll probably start this today. And next week, we'll finish this and we'll go over case studies. We'll talk some details about the case studies. I said next week, but is it next week? I think it's 2 weeks. Yeah, 2 weeks. Week 9, March 5th, our final class meeting. We'll finish anything that's left with the muscle bones. If there's people here, I'll answer any questions you have. And we'll go over what you need to focus on for the case studies. But this handout here is the muscles, bones, and mixed in with that ONE2 stuff. So this handout will contain a review of Anatomy Physiology 1. So there will be basic questions on like, what's this bony landmark called? What does this muscle do? Things like that. And then also mixed in with this handout, there'll be ONE2 questions about like thoracic out questions like about thoracic outlet syndrome, disc herniations, carpal tunnel syndrome. Like, what are those disorders? What kind of symptoms would the person have? What's that special test that you learned in class that tests for that disorder? So, this handout will contain all of that. Right. But looking at the time, that's good for me to take my second pause. And then we will come get started, get through part of this, probably finish it next time. So, take 10 minutes and then we will pick up here. All right, everyone. Let's continue here and then wrap up for the day. And then, like I said, we'll finish everything up in 2 weeks. So we meet again for our final meeting on March 5th. All right. So, like I was saying before, this handout is going to cover everything sort of ortho related. It'll cover the anatomy one, muscle, bones, that kind of stuff. And then it'll also cover mixed in with that the O&E stuff, O&E 2 specifically, the special tests and everything. So, I kind of have it all grouped together by regions of the body. So, first off, just a few overview things. And just FYI, this kind of stuff tends to be highly tested on second year comps. So, there's a reason this is a long handout. Definitely don't gloss over it. There's I wouldn't be surprised if 30 or so, like, well, maybe not, maybe 30 is a little much, but 20 or so, 22 questions are kind of just from this. A lot of muscle bone type stuff. Because acupuncture, a lot of what we're doing is orthopedic conditions. So there's a lot of muscle bone type questions and a lot of O&E2 type questions on the exam. So first off, though, just a few like very big overview points that come up like this, like the first day of anatomy one type stuff. You might get a general question about what is the integumentary system. You would just want to know that's essentially the surface structures. That's the skin, hair, fingernails, also includes sweat glands that are within the skin, all that stuff, integumentary system. I've not seen any questions that are really detailed questions about the skin or hair follicles or fingernails or anything. So you don't really get into the nuance of that anatomy or anything, but just know the expression tegumentary system. And also know skin, hair, fingernails, toenails, same thing, made out of keratin. So remember, keratin is the protein that's most highly concentrated in the skin. Your hair and fingernails basically are keratin. Like that's what those structures are. And that's the reason you often see keratin advertised as being in moisturizers and shampoos and things like that. Now, a lot of that's just marketing because applying it topically doesn't really, I mean, who knows, right? But it generally isn't really thought to do very much applying it topically because, the hair, the fingernails, all those things are composed of the protein keratin. So, I mean, it needs to be baked into the tissue. Applying some topically isn't going to really change the overall foundation of what the body developed. Then remember, there are different types of muscle. There's really three: smooth, skeletal, and cardiac muscle. I mentioned cardiac within here, even though I didn't list it in the header. But smooth versus skeletal muscle. First, the key things is you want to remember that smooth muscle is called smooth because it's non striated. So, skeletal muscle, if you look at it under the microscope, you see these bands, which is where the actin and the myosin overlap, and it creates these bands, what we call striations. Cardiac muscle also has striations. Smooth muscle, the reason we call it smooth is because you don't see those striations. The way the actin and the myosin intersect, it doesn't create that same appearance of bands. It looks more uniform. So there's no striations. That's why I call it smooth. And then, of course, smooth muscle is involuntary. Cardiac muscle, of course, is also involuntary. Skeletal muscle is voluntarily controlled. We use our skeletal muscle to move the skeleton, to move the bones, where smooth muscle, of course, is the muscle that's inside of our organs, other than the heart, because the heart has its own type of muscle, cardiac muscle. But smooth muscle is like in your GI tract, in the urinary bladder, the uterus, the gallbladder, etc. Go on and on. So all involuntarily controlled. And then you may get some questions about the proteins that make up muscles. So remember that there's four key proteins that facilitate muscle contractions within the muscles. Three of those proteins are exactly the same no matter what type of muscle you're talking about. So actin, myosin, tropomyosin, those are in all three types. The fourth type depends on the type of muscle. So remember that skeletal and cardiac muscle, the fourth protein is called troponin. Smooth muscle does not have troponin. It has instead something called calmodulin. It's just a different type of protein. Now you may remember that Calcium binding to the troponin or calmodulin is what initiates the muscle contractions. So calcium binds to either the troponin if we're in skeletal or cardiac muscle, or the calmodulin if we're in smooth muscle. Calcium will react with that. It changes the shape of the troponin or calmodulin. Then you might recall that pulls the tropomyosin out of the way and allows the actin and myosin to attach, to connect. And that ultimately is what leads to the muscle contraction. So again, make sure you know some of those key differences. Like you can get a question that says something like calmodulin is found in which of the following? And you need to know that it's found in smooth muscle. Now we'll go over this as we go through the various muscles and the various joints, but if you don't already have this down, make sure that you know your muscle, your joint motions, or you could phrase it, your muscle actions. You want to make sure you know the difference between flexion and extension, abduction, adduction, dorsiflexion, plantar flexion, eversion, inversion, etc. Now, as a general, we'll mention this as we go through some of the individual muscles, but remember that abduction is basically when you're moving in the frontal plane and you're moving an extremity away from the body core. So, like this would be abduction of the shoulder joint. Or you can say abduction of the humerus. Remember, you can phrase it by the joint or the bone where the motion is occurring. So it'd be the same thing to say abduction of the shoulder as it would be to say abduction of the humerus. You could phrase it either way. Adduction, remember, is when they're coming back towards the body core. So if you're in this position and you go back in this direction, that would be adduction. And the same thing would go for the hip joint and the femur, same kind of motions. Flexion versus extension. This is something that sometimes people confuse. So make sure that you're clear on this. The simplest way to think about it is that if you're in an anatomical position, flexion is always when the bone moves forward or anteriorly. Think F for flexion, F for forward. So like if I do this, that's flexion of my cervical spine. If I bend my whole torso forward, that's flexion of my spine as a whole. If I go like this with my humerus or my shoulder joint, that's flexion of the shoulder, flexion of the humerus. If I do the same thing with my femur, that would be flexion of the femur or flexion of the hip joint. If I go posteriorly, whether it be my neck, my shoulder joint, that's extension. Now, there is one exception. Remember the knee joint. The knee joint is the one exception. When you essentially put your heel to your butt, kick yourself in the butt, or you could say move your tibia in a posterior direction, that's flexion. That's flexion of the knee joint. When you're just standing normally, you're in extension of the knee joint. So the knee is the exception. Everything else, if the bone moves in a forward direction, that's flexion. If the bone moves in a posterior direction, that's extension. Okay. And eversion, inversion, I just want to highlight this one because this is one sometimes you'll forget. The foot, this only applies to the ankle joint. Basically, if this represents my foot, if I turn it inward, like towards my midline, that's inversion. If I turn it outward towards the exterior, that's eversion. That only applies to the ankle joint. And just lastly, before we go to the various regions of the body, make sure that you're clear that anytime you get a question about position, whether you get a question about muscle action or you get a question about whether something's on the right side or the left side or whether something's superior or inferior or so on, remember, you're always answering that question from the point of view of the person being in anatomical position. Right. So sometimes I've had this happen. I mean, even people far along in the program, well, I'll ask a test question or something, or someone will come up in class and people will act like, oh, well, it depends. Like, are you talking about the patient or you're talking about your right? Remember, it doesn't depend. It's always the reference subject. It's always their right, their left. And you always answer the question as if the person is in an anatomical position. So, in other words, my head is always superior to my feet. It doesn't matter if I happen to be laying down at the moment. If I'm in a doctor's office laying in a hospital bed or something, it doesn't change that. You still reference it as though we're talking about anatomical position. So just keep that in mind. All right. All right. So now we'll go through the various regions of the body. We'll highlight the anatomy that matters, that it's relevant. And if there is like some kind of O&E test or O&E condition, we'll go over that as we're going over that region of the body. So let's start with the head and the face. The head and the face, there's not really anything O&E wise that comes up. So mostly this is the same stuff that you would have had to study for first year comps. They'll ask you about like bony landmarks, what bone is a certain landmark located on? What bone does this other bone form a joint with? Things like that. They'll ask you about the muscles of mastication, the muscles that allow you to chew. That's mostly it with the head and the face. I've not seen any questions come up that get into like the muscles that make you smile or frown or wrinkle your forehead or, that kind of stuff. Even though technically you learn those, I don't really see too many test questions come up on comps about those kinds of muscles. All right. So, first, the bones of the skull. It's a really common question to come up on comps. What bones of the skull articulate with each other? Or another way of phrasing that is to say, what bones of the skull form a joint with one another? Make contact, in other words. Make sure you know the word articulate if you don't already. In this context, articulate means form a joint with. Now, remember the bones of the skull, there's one bone, well, really two because they're paired, that articulate with all the other bones. The parietal bones right up here on either side, they're going to form a joint with the frontal bone, they're going to form a joint with the temporal bone, and they're going to form a joint with the occipital bone. The parietal bones are the only ones that make contact or articulate with all of the others. And that is a misunderstanding that a lot of people have. Some people assume the frontal bone and the temporal bone make contact. So they think of the temporal bone as maybe making contact with all the others because, you would think like, well, temporal bone's here. So, okay, it touches parietal bone, it touches occipital bone, it touches frontal bone. But remember, the temporal bone and the frontal bone don't actually make contact. There are other bones in between them. They don't actually make direct contact with each other. And so that's a mistake that people can make on this kind of question. Now, as far as landmarks on the bones go, there's no pictures on the exam. You don't have to label anything, but they will ask you questions about like this landmark, what bone is it on? Or this bone contains which of the following landmarks? And mostly I would say they focus on the landmarks that come up in acupuncture locations. So that's the good news is you've had a lot of reinforcement on these. Most of it is not just pure rote memorization from a textbook. So the most common landmarks to come up as far as the skull goes, they're almost all on the temporal bone. So even if you've forgotten, like you're in the middle of the test, you're like, oh God, well, I forget which bone this is on. Like I know it's up here somewhere. Temporal bone is the answer to go with. So like this back here, the mastoid process, where you find a lot of your gallbladder points, that's a landmark on the temporal bone. It may not seem it, you might think, oh, it's back here. It's part of the occipital bone. You might think, but no, it's actually an extension of the temporal bone. The external auditory meatus, that one might be more obvious. That's the opening that the sound waves go through, basically through the ear canal into the portions of the brain that interpret everything. So that's part of the temporal bone, that little opening. This is just a little projection. You can't even palpate it, but there is something called the styloid process on there. And then this thing here, this little structure that kind of comes up and makes contact with the zygoma, we call it the zygomatic process. And it's usually pretty tender if you press on it. You may not realize that, but that's also an extension from the temporal bone. So all those things, temporal bone landmarks. You might get asked about the sinuses. Not really too much to say about the sinuses. Remember, those are hollow areas within certain bones of the face and skull that make the head a little bit lighter. And also, it allows our voice to sort of resonate and project a little bit more. If you get a question about these, you usually just get asked, what are the bones that have sinus cavities? And there's 4. They're paired, though: frontal, ethmoid, maxilla sphenoid. Sometimes people remember FEMS, FEMS as an acronym, frontal ethmoid maxilla sphenoid. The upper teeth and the lower teeth and the palate, make sure you know the bones that those are embedded in. So the upper teeth are embedded in the maxilla up here, lower teeth in the mandible. Pretty straightforward there. The roof of the mouth, of course, we call the hard palate, at least the anterior part. When you go further back, it becomes soft tissue, but the hard part is the hard palate. And remember, there's three bones that make it up. There's the maxilla, and even though technically there's a right and a left maxilla, they fuse. So you might think of that as one bone. And then there's a right and left palatine bone. So the anterior part of the roof of the mouth is maxilla, and then posterior, you have a right and left palatine bone. And those make up the roof of the mouth or the hard palate. This is another good example of something where, people might overthink it or think a certain option is too obvious. But no, the hard palate is made of bones called palatine bones. Palatine, like, yeah, you know, I don't know which came first, the name of the hard palate or the bones, but yeah, they're obviously connected. And again, don't overthink that. Don't think, oh, that's too obvious. That can't be the answer. It is. There is one random muscle that I have seen, like somewhat random, that I've seen come up on the comps as far as the facial muscles go, and that's the orbicularis oculus muscle. But this is another good example of where if you know a little bit about like medical terminology and stuff, the answer is kind of obvious because orbicularis kind of refers to like the orbits of the eyes, and oculus, a lot of you have probably heard like ocular as a word or a root word. Some that has something to do with eyes and vision. So orbicularis oculus is basically the muscles that go around the eye, and it facilitates things like blinking, squinting, that kind of thing. So the name really does kind of give away. And I think actually that's really what the question is. The question in the test bank is trying to get at. It's just like a process of elimination, like, okay, it's not these other options. And then also like, can people just sort of reason out like, via terminology, like even if they didn't study this exact muscle, could they reason out what's most likely the right answer here? So that's all that is. I just want to check one thing real quick. And then, of course, the facial muscles that do come up commonly are the muscles mastication. And remember, there's a little acronym for remembering these muscles. BITEM. Sometimes people just call them the BITEM muscles for buccinator, internal pterygoid, temporalis, external pterygoid, and masseter. These are the muscles that help us to chew. Most commonly, it's the temporalis and the masseter that tend to come up. I don't think I've really seen many questions that ask about the pterygoid muscles, but technically they're on the list. Right? So these are the muscles that facilitate chewing, the muscles of mastication. You want to know those. If somebody has an injury to one of these muscles, it probably affect their ability to close the jaw. All right. So pretty straightforward there. All this stuff should just be a recap of things you study for first year comps, really nothing new. Then going into the spine and the torso. So you could get questions about vertebra, as bones, some of the landmarks on vertebra. And again, this tends to stay very big picture. This mostly focuses on like the main borders of the vertebra and those parts that you palpate when you're doing point locations. It doesn't tend to get into the more like nitpicky crevices of the vertebra. Like I've never seen any questions about like the peduncles or anything like that. So basically, for comps purposes, you want to make sure you know the most anterior part of a vertebra. It's that circular shaped, almost like circular block. They call that the body of the vertebra. It's just simply called the body. The most posterior part, this is usually what we're counting when we're counting vertebra for point location. That's the spinous process. Typically, a vertebra has one spinous process. And laterally, there's usually a couple projections sticking out to the side. one on each side. So each vertebra typically has two transverse processes. Those are the main things to know as far as bony landmarks go for the vertebra. And just FYI, like, there are very simple questions like that in the comps database. Like, unfortunately, there was a couple of students this past term who they didn't pass their first year comps, and I was looking through their exam to give them some feedback. And it's almost always the case where the person didn't get like a 30%, they got like a 68%. One question would have made the difference. And like I was going through one of them, and it was like the student had answered that every vertebra has two spinous processes instead of one. And that would have made the difference between passing or not. So it's just like the things that come up repeatedly. I mean, you count spinous processes when you're doing point location. You get a lot of reinforcement in that. You want to make sure that you don't make silly mistakes. Take your time on the exam. Because sometimes too, I look at how long it took them to take the exam. They had an hour and 5 minutes and they finished it in 13 minutes. And then they made mistakes like that. It's like if they took their time a little more, they might have gotten that question and passed and been done with it. So yeah, take your time. All right. Now remember that there are a couple of vertebrae that are unique. So as a general rule, that's why I said here average vertebra. As a general rule, most vertebrae have a body, which is a circular block, basically. And then there's those intervertebral discs in between bodies. And then they have one spinous process sticking out the back and a couple transverse processes going out to the side. Most vertebrae, that's the case. Remember, there's two vertebrae that are unique and they get special names. C1, the first cervical vertebra, otherwise known as the atlas. Remember, what's unique about it is there is no body, there is no spinous process. It's basically a circular shaped bone with like a couple of condyles on it and a couple transverse processes out to the side, and the skull sits on top of it. Kind of a circular shaped bone that kind of holds the skull. So it doesn't have the usual shape. It doesn't have the usual structure. No body, no spinous process. Called the atlas. C2, called the axis, and this is more known for the extra thing that it has rather than something that's missing. The axis has a unique projection that sticks upward, a bony landmark that sticks upward, that's called the dens or the odontoid process. And that forms a pivot joint with C1, and C1 basically pivots around it. And it allows for rotation of the head and neck. It allows for movement like this. We call this the axis for that reason. And make sure you don't flip which one is which. That was another thing where I saw like one student who didn't pass, where it was like they said C1 was called the axis. Like that was the answer they selected. Then remember, when we're talking about the vertebral column, there's different types of curvatures. Remember, our spine is not just a straight, one straight, rigid, rod-like line. It has curvatures. So remember that it's normal for it to have anterior and posterior curvatures. It's not normal for it to have lateral curvatures. That's what we call scoliosis. But the anterior posterior curvatures are normal. And remember that if you're looking at somebody from behind, the lumbar and cervical sections will kind of curve inward. In other words, they'll be concave when you're looking at somebody's back. We call those lordotic curves. And the thoracic and sacral parts of the spinal cord, those will be coming more towards you. They'll be more convex. We call those kyphotic curves. And remember, those curves are normal, but sometimes people can have excessive curvatures in one way or the other, or lesser curvatures. So oftentimes when you hear about somebody being said to have like hypolordosis or hypolordosis, it means the lordotic curve is either excessive or not enough. But a plain lordotic curve in the lumbar and cervical region is normal. That's what you would expect to see as a lordotic curve. And then the ribs, hopefully you'll get some of these questions because, the ribs are very straightforward. True ribs, ribs 1 through 7, that means they wrap all the way around. They start at the spine and they go all the way around to connect directly to the sternum. So there's a joint with the sternum, there's a joint with the vertebral column, ribs 1 through 7, all the way around. We call those true ribs. And of course, it's on each side. Ribs 8 through 10, there's an indirect attachment to the sternum via massive cartilage. So basically, the ribs start at the vertebral column, they come around to the front, they connect to a massive cartilage, and then the cartilage connects to the sternum. Those are referred to as false ribs. And then ribs 11 through 12 don't connect to anything on the anterior side. They start at the vertebral column, they come part way around, and they just float out there. There's muscle and stuff connected to them, but they don't attach to any other bone or cartilage on the anterior side. So we call those floating ribs. And floating ribs can also be considered to be false ribs, but typically with 11 and 12, we just specify them as floating ribs. All right. So those are some key bony landmarks and stuff that you want to pay attention to. And we do now have a few O&E tests that relate to the body core, that relate to the torso, and relate to the spinal column and whatnot. So let's go over the O&E tests that apply here. So the way these questions tend to come up on the exam is there's a few ways they could present these questions on the exam for O&E. One, they could just give you signs and symptoms and say, what condition does that sound like? Just based on the signs and symptoms. They could ask you the underlying mechanism of a certain disorder. Like, for example, you could know that like thoracic outlet syndrome is when the brachial plexus and subclavian artery and or vein are being compressed in the thoracic outlet, something like that there's compression on one or more of these structures. That's the mechanism behind thoracic outlet syndrome. So you could just be asked about the straight, mechanism behind a disorder. Sometimes you could just simply be asked, what test would you use to test for a disorder? So they might tell you, for example, that if a person has cervical nerve root impingement, which of the following tests do you suspect would be positive? Something like that. So you'd want to know the tests that are used to test for this condition. They might give you a case study where they give you signs and symptoms, and on top of it, they tell you such and such test was positive. So yeah, definitely a big thing you want to make sure you know is what O&E tests go with what condition. If a certain test is positive, what condition does that mean they have? That's a big thing that you want to know. Remember, you don't have to perform these. There's no practical. You just have to be able to answer test questions, written questions. Okay. And then, of course, there might be a question. There might be some questions describing the test, like describing how you do the test. And, which of the following is a correct description for a certain orthopedic test. So those are the kinds of things that might come up here. But again, all written questions, all multiple choice. You just have to be able to recognize the right answer. You don't have to be able to perform it under pressure or anything like that. So let's start with some of these conditions and work our way down. So one possibility is a person can have a cervical nerve root impingement. What that means is that the nerve roots that are exiting the spinal column and ultimately feed into peripheral nerves might be getting pinched. So there might be some kind of compression on a particular nerve root. And that would typically cause pain in the area of compression, but that pain would also radiate down into a specific dermatome. So we mentioned that earlier. So, for example, if somebody had their C6 nerve root being compressed, there might be some neck pain that radiates down the arm into this area that we think of as the C6 dermatome. They might also have weakness in the related myotome. So C6, you might remember that's wrist extension. So they might also have some weakness with wrist extension if there was some kind of compromised C6 nerve root. Now, the applicable O&E2 tests that you could do to test for such a condition, there's two of them. You could do the foremenal compression test or distraction test. Remember that the way a lot of these ONE2 tests work is that you're reproducing the mechanism of injury or the mechanism behind their symptoms. Or in some cases, you're relieving it. You're doing something that you would expect would relieve it. Those are a little nicer, but unfortunately, they're not always something that could be done. A lot of times we're reproducing it and saying that, like, does this exacerbate it? And if, like, essentially reproducing the underlying mechanism exacerbates it, that gives you kind of a clue as to, oh, okay, it's what I was thinking. So the test, the foraminal compression test, this is the one you typically have the patient seated, looking forward, and you basically press down on the top of their head. And essentially, what you're doing by doing that is the openings where the nerve roots exit, you're making them smaller. By pressing down, you're making them smaller. And so if there is a nerve root that's being pinched, you're going to likely pinch it more, and they're going to go, oh, yeah, that's making it worse. That would be a positive foraminal compression test. Remember, positive meaning that, like, they're positive for the condition, not positive like it's a good thing. And you might do that in different positions. Like, you might have them, okay, let's try it now with your head turned this way. Let's try it now. You might remember like Sperlings. Let's have them extend and turn, and let's try it that way. I've not really seen the comp exam though go into all those particulars, just the basic idea. So you press down. Oh, yeah, that makes it worse. That kind of reinforces the idea that it's a nerve root being pinched. Now, a little friendlier, you could do the traction test. That's where you put some traction on the neck, like support the underside of their chin here, support the underside of their occipital bone, lift up. Now you're pulling those bones, those vertebrae further apart, creating some traction. And now that should maybe relieve any kind of pinched nerve. And she's like, oh, yeah, that feels better. But those kinds of tests aren't always available to or realistic, because sometimes when people come in and they have these problems, it's not necessarily every second of every day. It's something they experience periodically based on certain positions. So distraction test really only works if they're like currently feeling the pain. So then you can go like that and go like, does that make it better? If they're not currently feeling the pain, the distraction test wouldn't really tell you much. So sometimes it's available. Sometimes it just doesn't really make sense to do. Then another possibility, let's say foraminal compression test was negative. They're like, no, that's fine. Not really noticing any difference. So then you're thinking, all right, well, what else could possibly cause some pain in this region that radiates down into the arm? What else could maybe cause that? Well, maybe it's not like in the spinal column itself. Maybe it's like a brachial plexus injury. The brachial plexus maybe got stretched or damaged in some way. That happens sometimes if somebody like grabs you by the arm and pulls, it might tear the brachial plexus a little bit. If you're hanging from something, I mean, it's possible that could tear the brachial plexus if, particularly if it happened like suddenly or something. So the way to test for that is to put tension on the brachial plexus. So the test would be, usually the symptoms are pretty similar to a nerve root impingement, except it might not be specific to any one dermatome. They might just feel the pain more generally in the arm. But what you would do to test for it is put tension on the brachial plexus, what they call the shoulder depression test. You basically do this. You stretch out the brachial plexus. So you push the shoulder down on the affected side, and then you, as the examiner, tilt their head to the other side. Ooh, nice little crack there. What you're doing is you're putting tension on the brachial plexus. So if that makes it worse, that indicates maybe it's more of a brachial plexus lesion. Another possibility is maybe the person just has like tight muscles, like a tight SCM or tight trapezius or tight joint an injured joint capsule or something. So there is a test called O'Donoghue's maneuver. And the basic concept could apply to any joint, but O'Donoghue's maneuver is specific to something going on up here with the trapezius and the SCM. So let's say somebody comes in, they've got some neck pain, some tightness, maybe they're feeling it like kind of down here a little bit in the shoulder. So, all right, brachial plexus test was negative, foraminal compression test was negative. Like, what else could it be? It could be that there's some kind of injury, some kind of inflammation of the inert tissues, like the joint capsules and the vertebra. It could be that the trapezius, for example, maybe there's a muscle tear or muscle tightness in there. So, with O'Donoghue's maneuver, typically what they do is they'll kind of go through two steps. First, they will do resisted range of motion. All right. And so that would be like, okay, push your head into my hand. Okay, push this way, push that way, push that way. If that elicits pain, if that makes their symptoms worse, that indicates it's more of a muscle issue. It's like a muscle tear, muscle injury of some sort, because it's made worse when you're using the muscle against resistance. So then you just kind of think to yourself, well, what muscle perform causes that action? So what muscle does flexion of the neck? Oh, SCM does that. What muscle does extension? Oh, that's more the trapezius, that kind of thing. Let's say that's negative though. Then you could do passive range of motion testing. That's where you can just, as the examiner, okay, don't help me, don't fight me. I'm just going to kind of move your head in various positions. And if those kinds of things create pain, that would indicate that it's more of like more the inert tissue, something like a joint capsule, ligament, something like that. That's the problem because they're feeling pain even when they're not using their muscles. That's the idea. So again, you could apply that concept really to any joint, but when they talk about O'Donoghue's maneuver, which is one of the tests that is considered fair game for the comp exam, they're referring to the neck region. So this test specifically applies to problems with the neck, but you could do that same, follow that same concept with any joint. Another disorder is people can have a facet joint dysfunction. So remember that basically in between vertebra, there's three joints. There's body to body, the vertebral body to the next vertebral body forms a joint with the intervertebral disc in between. And there's a right and left facet joint. The facet joints are more on the posterior aspect of the vertebra. And sometimes what happens is those facet joints get irritated. Somebody sleeps funny and maybe their facet joints get a little jammed, a little irritated in their neck. Sometimes from sitting for long periods of time, the facet joints in their lumbar spine get irritated. It tends to be most common in the lumbar and cervical areas. The main test for this refers to the as referencing the lumbar area. It's Kemp's test. And Kemp's test is the one where you, as the examiner, support their pelvic structures, and then you help them to extend back and rotate. And if that makes their pain worse, if they're coming in with some kind of lumbar pain and extension makes it worse, that would indicate some kind of a facet joint dysfunction. That would be a positive Kemp's test indicating some kind of facet joint injury. As a general rule, facet joint injuries are generally made worse with extension because they are on the posterior aspect of the vertebral column. So when you extend, it kind of jams them and irritates them a little more. And they're usually made a little bit better by flexion because that kind of opens them up, pulls them apart so that you're not getting as much friction. So as a general rule, if extension makes a back problem worse, you're thinking possibly facet joint problems. If flexion makes a problem worse, you're more likely to think disc herniation. So when you flex forward, that compresses the disc in such a way that it pushes the disc posteriorly, and then the disc compress into a nerve root. So typically herniations worse with flexion, facet joints worse with extension. Again, as a general rule, there's always, There's always people that don't, that are exceptions, don't fit the general rule. You always have to keep an open mind, but that would be like the first thing you're thinking. Scoliosis, I think we already mentioned this. Scoliosis is when there's an abnormal lateral curvature of the spine. And the test for this is the thing that you might have done in the nurse's office back in, your elementary school days, where you had to go to the nurse's office and they would check your vision, check your hearing, things like that. One of the things they often also checked for was scoliosis. So they would have you do what's called Adam's test. And this is just very simple. This is just sort of bend over, flex your spine, touch your toes type of position. And the examiner is looking at the spine as you do that. And basically, they're looking to see if there's any kind of hump or depression or any kind of lateral curvature when you're in that position. Because if in that position they're seeing one side of the ribs higher than the other, or depression or a curve, that would indicate structural scoliosis. Sometimes people look like they have scoliosis when they're standing or they're sitting, but it's just because of bad posture. They're just slouching or something like that, or, sometimes so they kind of lean to the side. When they lay down, lay back, they're kind of off to the side. That could just be like that posture type of thing. But if you have the person actually bend forward and touch their toes, those things should disappear. And if they don't truly have scoliosis, you should see a nice straight spine with no depressions or no raised areas. If you do see a depression or a hump or something, that would indicate they have true like structural scoliosis. That would be a positive Adams test. Oops. Then we have disc herniation slash sciatica. Now, I just want to be clear about this, like my notes and what's intended here. We're not saying that a disc herniation is sciatica. Like they are technically different things, but typically they go together. A disc herniation in the lumbar spine is often what creates sciatica. So what happens is that the disc is bulging posteriorly and usually off to the side a little bit too, a little bit laterally, and it's pressing into the nerve roots that contribute to the sciatic nerve. So the disc herniation then leads to the person experiencing that pain that goes down the back of the leg that we call sciatica. So those often go together. Typically is worse with flexion because when somebody flexes forward, that is going to compress the anterior part of the disc and cause it to bulge in a posterior direction. And that will put more pressure on the nerve root. And so if you're testing for this, you want to reproduce that, but you want to reproduce it in a controlled way. So rather than telling the patient bend over or something, which, they might go too far, they might make their disc herniation worse, you do it in a controlled way. You have them lay down on the table and you raise their leg up. That's essentially putting them into a flexed position, right? That is putting their femur closer to their torso, which reproduces what happens when you bend over, but just in a more controlled way. So we call that straight leg raise, the straight leg raise test. You raise their leg up, and if that causes them some, if that exacerbates their problem, like, oh yeah, back is feeling much worse. Oh, ouch, ouch. Oh yes, feeling that pain down my leg. That would be a positive straight leg raise test, indicating disc herniation, possibly contributing to sciatica. Now we have three tests here because there's kind of three things that you could do together. They're all technically separate tests, but you do them together and they're all testing for the same thing. So let's say you bring the leg all the way up and, they're not quite feeling it. They're not like, oh, I don't know, it's fine. Well, one thing you can do is you can dorsiflex the ankle. And what that will do is that will pull on the sciatic nerve because the sciatic nerve goes all the way down to the ankle. It will pull on the sciatic nerve, but it doesn't involve the hamstrings. So it's a way of adding tension to the sciatic nerve without putting tension on the hamstrings themselves, which a lot of people have tight hamstrings. So because one of the problems with this test potentially is some people might say, "Oh, the back of my leg hurts," but really it's just they have tight hamstrings, not really that they have a sciatic nerve issue or disc herniation. So one way around that is, you go up as far as you can, and they're like, "No, I'm not feeling it," or maybe they are feeling it a little bit, but you're like, "Okay, well, I don't know, that might just be their hamstrings." So you could back off a little bit and then do the dorsiflexion of the ankle. We know that that will pull on the sciatic nerve, but that doesn't involve hamstrings. So if that exacerbates their symptoms, it's a sciatic nerve issue, probably a disc herniation pressing into that. And when you make the nerve more taut, that's just further pulling it into that herniation. So that part of it is called Bragger's test with the dorsiflexion of the ankle. Again, you're really doing it along with straight leg raise. That's why we're talking about them together, but technically they're separate tests. And then also with this, there's what they call the well leg raise. Again, it's all part of the same thing because essentially a well leg raise test means you're lifting one leg, but they feel pain down the other leg. So the leg you're lifting doesn't have pain, but they feel pain shooting down the back of the other leg. That indicates a central disc herniation. So it indicates basically the same thing, but it just saying the orientation of the herniation is more central rather than out towards one side or the other. So yeah, all of these are basically testing for disc herniation contributing to sciatica, but there's just some slight differences between them. And then lastly, and this we'll call it today, and then we'll pick up our next class meeting with the extremities, is thoracic outlet syndrome. So first, make sure you know basically what it is. There's a little opening, a little tunnel essentially from the cervical spine through the scalenes, under the clavicle, you know, between the clavicle and the first rib. There's basically a little bit of an opening that allows the brachial plexus to move through there, the subclavian artery that's delivering oxygenated blood to the upper extremity, as well as the subclavian vein that's taking the deoxygenated blood back up from the upper extremity. Sometimes things are out of position. Sometimes certain muscles are tight. Sometimes the first rib is out of position. Sometimes people have an extra rib. Sometimes a vertebra might be out of alignment. Whatever exactly it is, sometimes things intrude into that thoracic outlet and they put pressure on one or all of these things. Puts pressure on the brachial plexus, the artery. The vein's usually not the biggest issue, but could also compress the vein. And then that leads to symptoms. So if the brachial plexus is being compressed, there'll usually be like pain, numbness, tingling, that kind of thing. Most commonly, it starts in the medial aspect of the forearm and into the fourth and fifth fingers, but it could affect the entirety of the forearm if the compression gets worse. But it usually does tend to start in the medial aspect with the fourth and fifth fingers. If the artery is being compressed, now there's not going to be as much blood flow down the upper extremity. So it gets cold compared to the other side. It looks more pale, might even look a little cyanotic compared to the other side. The pulse won't be as strong. So in the non-affected extremity, you might feel a good, healthy, strong pulse. But in the affected extremity, you might notice that there's a weakness in the pulse because, again, the blood flow is being cut off. So these are the kinds of symptoms that you might see with thoracic outlet syndrome. And then the tests, there's 3 tests you can use to test for it. Adson's and Halstead's. Those are very similar to each other. Remember, with Adson's and Halstead's, in both cases, the person's upper extremity is kind of at their side, being pulled back a little bit. The arm is somewhat externally rotated, so they're kind of supinated and the shoulders externally rotated. Those are positions that'll tend to exacerbate thoracic outlet syndrome. A couple of key differences, though. In Adson's, the patient's told to hold their breath and look towards the doctor who's over here feeling the pulse. So look towards the doctor. In Halstead, they're looking away. That's kind of the main difference. So sometimes people remember, like, if the doctor has halitosis, you want to look the other way. And that's how they remember Halstead's the one where you look away. And the doctor is over here feeling the pulse. And if this position either exacerbates their symptoms, where they're like, oh yeah, my pain's tingling, it's getting worse, and or the doctor notices the pulse disappears or gets weaker in that position, either one or both, those would both be positive for thoracic outlet syndrome and indicate thoracic outlet. Ruse test doesn't really come up as often, but technically it's on the list from the comp study guide that the college puts out. It's technically on the list of tests you need to know. Ruse test is just this one. You may remember it. You have the patient hold this position and go like that. And typically what's going to happen is the side that has thoracic outlet is going to start to cramp up. So like the others maybe still going, they feel fine, plenty of blood flow, the muscles just kind of keep doing their thing, and the other side like starts to cramp up. So that would be a positive Ruse test indicating thoracic outlet on the side that cramps up. All right. All right. So that's where we will end it today. Remember, our final class meeting will be in 2 weeks. That'll be March 5th, week 9 of the term. That'll be our final class meeting. We'll finish this up. So we'll finish up the anatomy O&E, and then we'll talk about case studies, what you need to know for the case study section. And then, if there's anybody here live and you have questions, you could certainly show up with a lot of questions. If not, if questions come up, you could always email me and stuff. So anyways, that's where we'll call it for today. So have a good day, everyone.